Hi, this is mine and Catherine's project on the innate and adaptive immunity in multiple sclerosis. Enjoy. Thanks. Multiple sclerosis is known as an autoimmune inflammatory disease affecting both the brain and the spinal cord, and does so by damaging protective coverings on the nerves called myelin sheath, interrupting the communication. MS has two stages, the first being the relapsing remitting stage, defined as having attacks with new or increasing symptoms, which can be categorized as active or being in remission, as well as worsening and not worsening based on disease progression. The second stage is secondary progressive, which follows the relapsing remitting stage, which is often seen as progressively worsening within the disease progression. MS symptoms vary depending on nerve damage progression. It also differs person to person. For example, some people might experience optic neuritis, scotomas, which is spots in the vision, numbness, weakness in the limbs of their body, or loss of coordination of bladder and bowels, or dysphagia, which is the weakness in the muscles used for speech. This disease can be seen as early as 15 years old to as late as 50 years old and is most commonly seen in European descent. For every one man affected, two women are affected. The relapsing remitting stage is the most common, affecting approximately 85% of people. There is no true treatment just yet, just physical therapy and occupational therapy, and a new drug therapy containing corticosteroids or blockers for norepinephrine receptors. For diagnosis, MRIs are your best bet, but there is no true definitive test for diagnosing, but MRIs are the best for monitoring. In this slide, we found a funny little comic that describes what multiple sclerosis is as a disease and a few different symptoms that I didn't mention previously that a person might experience with the disease, as well as different treatment options and the expected time frame of when multiple sclerosis is diagnosed or symptoms start to show. For our innate hypotheses, we have one being the progression into secondary progressive MS leads to the overproduction of pro inflammatory cytokines, interleukin 12, and tumor necrosis factor alpha. Then the second is progression into the secondary progressive stage leads to overproduction of anti inflammatory cytokines, interleukin 4, and interleukin 13. Then for adaptive data, we have the hypotheses overproduction of norepinephrine could decrease inflammation from interleukin 17 and interferon gamma. And then secondly, we have decreased norepinephrine production increases inflammation from interleukin 17 and interferon gamma and leads to more nerve demyelination as seen in the relapsing remitting stage. In Graph A, we will be discussing dendritic cell activation of co-stimulatory receptors and expression of antigen presentation. As we can see in the graph, relapsing remitting stage had higher levels of pro-inflammatory signals from CD80 compared to the secondary progression stage. This could be the reason why the disease transitions from the relapsing remitting phase to the secondary progression stage. We also see there is no significant difference in the expression of HLA-DR and CD86 between both groups. And we can also see there is a significant more expression of CD80 in the secondary progressive stage than in both the control and the relapsing remitting stage. We also see from this graph that both the relapsing remitting stage and secondary progressive stage both significantly have higher levels of CD40 being expressed than in the control group. And then we also see that there is significantly less PDL1 expressed in the secondary progressive phase compared to the control and the relapsing remitting stage. In Graph B, we will be discussing dendritic cell production of pro-inflammatory cytokines. As we see in the graph, the relapsing remitting stage of patients had higher levels of pro-inflammatory cytokines, IL-12 and TNF alpha, compared to both the control and the secondary progressive stage. Then we also see that there are significantly higher levels of IL-12 and TNF alpha expressed in the secondary progressive stage than in the control and relapsing remitting stage. We also see from this data high levels of cytokines in secondary progressive stage, which may suggest the responsibility for the continued damage of the neuron myelin sheath. The high level of TNF alpha produced in the secondary progressive stage might also suggest the responsibility of the reason why it is known as the progressively worsening stage in the terms of the amount of symptoms one may experience or how bad the symptoms that person is experiencing at that time. In this last portion of our innate data, we will be discussing differentiation effects on naive T cells, as shown in our graph C. So we see that secondary progressive stage shows a more increased production of type 2 anti-inflammatory cytokines, which are known as IL-13 and IL-4. This results that the disease is experiencing a degenerative effect due to the relapsing remitting phase. We also see a significantly higher amount of IL-13 and IL-4 being expressed in the secondary progressive stage than in both the control and relapsing remitting stage. It could be suggested that if a person is undergoing more production of anti-inflammatory cytokines IL-13 and IL-4, that they might be experiencing the remission portion of the disease, also known as the healing portion of the disease, where a person may not be experiencing as many symptoms, new symptoms, or nearly as bad of symptoms.
Stimulation of T cells from interleukin-17 production. This figure demonstrates MS patients and a healthy patient's CD34 T cells stimulated with different norepinephrine concentrations, and interleukin-17 production levels were measured. In MS patients, there was significantly less interleukin-17 production levels in 10 to the negative 4 molar norepinephrine-coated cells than in 10 to the negative 5 molar norepinephrine-coated cells. Similarly, in healthy patients, there was significantly less interleukin-17 production levels in 10 to the negative 4 molar norepinephrine-coated cells than in 10 to the negative 5 molar norepinephrine-coated cells. Differentiation of T cells based on IFN gamma production. This figure demonstrates MS patients and healthy patients' CD34 T cells stimulated with different norepinephrine concentrations, and IFN gamma production levels were measured. In MS patients, there was significantly less IFN gamma production levels in 10 to the negative 4 molar norepinephrine-coated cells than in 10 to the negative 5 molar norepinephrine-coated cells. Similarly, in healthy patients, there was significantly less IFN gamma production levels in 10 to the negative 4 molar norepinephrine-coated cells than in 10 to the negative 5 molar norepinephrine-coated cells. Researchers confirmed that norepinephrine causes an anti-inflammatory effect in the body by decreasing the production of pro-inflammatory cytokines interleukin-17 and IFN gamma. This was shown in figures A and figure B. Peripheral blood mononuclear cells stimulation from interleukin-17 production. This figure demonstrates MS patients and healthy patients' peripheral blood mononuclear cells being stimulated with different norepinephrine concentrations, and interleukin-17 production levels were measured. In MS patients, there was significantly less interleukin-17 production levels in 10 to the negative 4 molar norepinephrine-coated cells than in 10 to the negative 5 molar norepinephrine-coated cells. Similarly, in healthy patients, there was significantly less interleukin-17 production in 10 to the negative 4 molar norepinephrine-coated cells than in 10 to the negative 5 molar norepinephrine-coated cells. Peripheral blood mononuclear cell stimulation from IFN gamma production. This figure demonstrates MS patients and healthy patients' peripheral blood mononuclear cells stimulated with different norepinephrine concentrations, and IFN gamma production levels were measured. In MS patients, there was significantly less IFN gamma production levels in 10 to the negative 4 molar norepinephrine-coated cells than in 10 to the negative 5 molar norepinephrine-coated cells. Similarly, in healthy patients, there was significantly less IFN gamma production levels in 10 to the negative 4 molar norepinephrine-coated cells than in 10 to the negative 5 molar norepinephrine-coated cells. Based on the figures A, B, C, and D, it is noted that increased norepinephrine concentration decreases interleukin-17 and IFN gamma production, while decreased norepinephrine concentration levels increase interleukin-17 and IFN gamma production. This observation was noted in peripheral blood mononuclear cells and CD34 T cells in both healthy and MS patients. To properly treat MS, damage to the myelin sheath needs to be prevented. Treatment plans include inhibiting pro-inflammatory cytokine production of interleukin-17, IFN-gamma, TNF-alpha, and interleukin-12. Another treatment plan would be inhibiting norepinephrine uptake to prevent increased pro-inflammatory cytokine production of interleukin-17 and IFN-gamma. Administering corticosteroids and pro-inflammatory cytokine antibodies would also aid in reducing inflammation and suppressing the immune system. Overall goal of treatment is to prevent relapsing remitting MS from transitioning to secondary progressive MS and further prevent myelin sheath damage. These are all the sources that we use for the presentation.